Hey guys, it's Dr. Alicia and Dr. Sarah here. We are back in our video series around labor and delivery. We've got a bunch of videos in this series, so check them out. They're all in the show notes below. Today we are talking about induction of labor and augmentation of labor. So if you like these topics, hit subscribe below. Check out our website at www.shefoundhealth.ca. We've got lots of great info there. We also have online prenatal classes coming up. So if you sign up for our community, you'll get all the notifications of the new stuff that we have coming out and any courses that we have coming up on offer. Also, check out the show notes. Our disclaimers are at the bottom. Have a read of that. And anything that we mention in the podcast, we'll link below as well.
So, what is induction? So, induction is when we help get your labor going. And that can be done for a lot of different reasons. So, typically, I think probably one of the most common reasons we do it is post dates. So, that means that you've come to your due date, and here our practice is if you've gotten to about 10 days past your due date, and there's still no signs of labor, then we would talk about inducing you and getting that labor going.
And the reason we want to do that is we hope to have all babies delivered by 42 weeks of gestation if you're otherwise healthy and under the age of 40. We know that at about 42 weeks, your baby outgrows your placenta's ability to feed it. And so there's a slightly increased risk, but we do not accept a slightly increased risk of stillbirth after 42 weeks. So that's why we try to get that process started around 10 days after your due date, or 41 plus 3, because it can take a couple of days sometimes to get you into labor and meet your cute baby. So we want to have that whole process complete if we can by 42 weeks.
Mm-hmm. Another reason we would offer an induction is for women who are I tend to say mature mothers, but the technical medical term is advanced maternal age.
And don't worry, we'd both be in that category right now.
It's true. Actually, I was for 2 of my 3 babes. So advanced maternal age is above 35, but we don't typically offer induction until women reach the age of 40. And at that, if you're 40 years old, or you're going to be 40 at time of delivery, we would offer an induction when you hit 40 weeks instead of at that 42-week mark.
Another reason that we offer induction early is if you have medical complications of pregnancy. So this can include hypertension in pregnancy that is relatively well controlled. We would want to deliver you a little bit sooner, so often around 38 weeks. We offer you induction if you have gestational diabetes and you're on insulin. We would offer you induction before you get to your due date as well. And there's a few other medical reasons that we would offer you induction before you actually hit your due date as well. And those should be pretty clear, and your provider should have had these conversations with you before you get to that point.
Exactly. And the last sort of common reason for induction, because there's all sorts of always case-by-case unique situations, but another common reason for induction is what we call multiple pregnancy. So when you've got more than one babe in there. So if you've got twins, triplets, or beyond, typically we're going to talk about delivering those babies well before their due date.
Yeah. Oftentimes they actually deliver themselves well before their due date because your uterus can only get so big, to be honest. But anyways, if you don't do it on your own, that's when we talk about helping your body along.
Yeah.
So how do we do it? And there's 4 main reasons, ways that we would do it. So the first thing we need to consider is how ripe is your cervix. And when we talk about ripeness, we talk about how long is it. So it usually starts off about 4 centimeters long and then shrinks down throughout pregnancy and labor. How firm is it? So firm would be like your nose, soft like your cheek. How dilated is it? So is it closed, or does it have a little bit of dilatation to it? And where is it positioned? So is it really far forward or is it way back? And we feel like we're reaching for your tonsils trying to find your cervix. That would be a posterior cervix. And also how high up is your baby in your pelvis? So we take those factors into consideration to determine your ripeness. And based on that, we would decide what way we would offer you to get that induction started.
So for someone whose cervix would be considered unripe, so that means their cervix is still long, it's not really opened up, it's still quite firm, perhaps sitting far back, we typically offer something that we call Cervidil. So what Cervidil is it kind of looks like a flat tampon, and it's infused with something called prostaglandins. And what we do is we take a sterile glove and we put that cervical and we tuck it up in the vagina to sit just behind the cervix. And what that does is it's basically what I tell people is a synthetic version. So it's a man-made version of a protein that your body naturally would be producing in sort of the weeks to month leading up to delivery. So what it does is it sort of stimulates your uterus to contract down in the lower part, soften that cervix, and start to open it up.
The other way that we can ripen a cervix is something called a Cook catheter, or some places use a Foley catheter. So same as we would use to put into your bladder through your urethra to help you pee. So a Cook catheter is a long tube. It's got two balloons pretty close to each other that we fill up with water or saline, and that goes all the way up into your uterus. So we want the top balloon in your uterus at the top of your cervix. We want the lower balloon in your vagina underneath your cervix, and it's squeezing your cervix together, so it's both shortening your cervix and it's pulling down. Gravity pulls it down, so that helps to dilate your cervix out. So that is really effective at kind of getting your cervix to that point that we can start the next phase of the induction. Both a Cook catheter and the Cervidil, in Victoria anyways, we leave in for about 24 hours. We make sure that baby is happy and tolerating things before we either send you home or tuck you in to the ward, depending on the complexity of your pregnancy. And then we'd reassess you in about 24 hours, or if things change throughout that time, which we'd give you clear instructions on before you go home.
So those are sort of the two cervical ripening methods. And for those of you who have a hard time understanding, my husband, who happens also to be a physician, but is fearful of doing maternity care, says we have to open the garage door before we can drive the car out.
Yes, that's a good one. I like that.
Yeah. So once we've got that cervix ripe, so meaning thinned out, opened up, moving forward, there's two additional things that we can do. So sometimes women come in and they're already sort of cervixes open, thinned out, and we can jump to these right away. Other times they've had a Cervidil or a Cook, and then this is the next step of the induction. So the first thing we can offer is what we call an artificial rupture of membranes. So that's when we, physicians or care providers, break your waters for you. So it's not overly painful compared to a regular vaginal exam. And we take a small plastic, it kind of like, I hate saying this, but it kind of looks like a crochet hook.
Oh yeah, the nurses use them to crochet in the lounge on their break sometimes when they're desperate for something to do.
I did not know that.
Yeah, they do.
Oh my gosh.
Yeah.
Anyways, and we just, so picture your, the membrane sort of like a balloon, and we just make a little nick, create a hole, that fluid starts leaking out, et voila. Sometimes that in itself can be enough to start contractions and get your labor going.
We only do that if baby's head is nice and low in your pelvis and we feel like it's safe to do. There's a very small risk if your baby's head is high up that the umbilical cord can come underneath your baby's head and then it can get squished, and we don't want to risk that. So if that's the case, then we'll use something else called oxytocin, which is a hormone that we give you through the intravenous, or medication that we give you through the intravenous, which is very similar to your own natural hormone of oxytocin that gets your uterus cramping. So that cramping helps to bring baby's head down into a safer spot that we can then, if we need to, rupture your membranes.
So those are the methods of induction. So something else that we often can offer women in labor for multiple reasons is something called augmentation. So an augmentation is oftentimes when we give medication to help your body's own contraction. So this can happen oftentimes if women have had prodromal labor for days and things are just not getting going, or they're in labor but we're just not seeing the frequency or the strength of contractions that we need to get that cervix dilated and deliver your baby.
Yeah. And so what we use is very similar to what we would use for an induction as well, except you're generally ripe at this point. So we can offer, if you haven't broken your waters naturally, we can offer breaking the waters. What that does is it just allows that uterus muscle to become a little bit more contracted to work more effectively. So how I describe it is if you're trying to lift a heavy weight with a straight arm, your muscle fibers are much longer and they're less together like this, and so they just don't work quite as well. But if we can shorten up that muscle, so bring your arm to a 90 degree, you're able to carry more weight, right? Yeah. And so then your uterus just can contract more effectively, get stronger, and move that baby down to dilate out your cervix. So that's the rupture of membranes. The other thing that we can use is that oxytocin, which is through that intravenous again, to help make your uterus contract more strongly.
And when we do that, so when we offer oxytocin, we know it can cause quite strong contractions. So we do, at this point in time, always make sure we're continuously monitoring that baby. So we're constantly listening to the baby's fetal heart. And the nurse is there sitting by your side, keeping an eye on things as well.
Yeah. So we do have a few tricks up our sleeve if you're not getting into labor on your own, or if we need to help things along because of medical reasons or post dates. So fear not. We also want you to have a nice normal vaginal delivery. So these are kind of some of the tools in our toolkit that we can use to help you along to achieve that, if that is what your goal is as well. But anytime that we're inducing labor or augmenting labor, if we are using medications such as oxytocin, we need to be careful and we need to monitor your baby. So generally speaking, you have monitors on. Some of those are telemetry, so you can walk around with them. Some of them are even waterproof. But we do need to be careful and keep an eye on your baby, because we are causing your uterus to contract more strongly.
Yeah.
So that's about it for induction and augmentation of labor.
Straightforward.
Pretty straightforward. Easy peasy, lemon squeezy. So hopefully that was useful. If you thought so, subscribe below. Also, check out these other videos in the same series, and check out our website at www.shefoundhealth.ca. Have a great day.
Thanks for watching.